amplitude is higher in newer left bundle branch blocks, and T-wave amplitude with time it goes down, but I don't think we are using this hypothesis in our clinical practice. Acute MI with LBBB, it could be acute MI with pre-existing LBBB. It is difficult to diagnose, but if we apply some criteria, this Sargosa criteria is very popular, all of you must be knowing. The feature suggestive of acute MI in LBBB is the ST changes in same direction, either concordant ST depression or concordant ST elevation in limb leads more than 1 millimeter, or discordant ST elevation, which is usually there in LBBB 2 or 3 millimeters. If it is more than 5 millimeter in precordial leads, then it suggests MI. And STT changes in the same direction as QRS complex, that suggests acute ischemia in cases of LBBB and suggests that these are the primary STT changes. This is one example, patient of LBBB presenting with MI. You see ST elevation here, which is concordant to the QRS complex more than 1 millimeter. This is discordant concordant ST depression 1 millimeter, and then STT changes are in the same direction as QRS complex. Another scenario, very common scenario and very important in clinical practice, is left bundle branch block in patients with heart failure. This is definitely different population, needs to be treated differently than those who doesn't have left bundle branch block. Almost 28%, few studies say up to 40% of heart failure patients have conduction abnormalities. Specific data is not available, but most of them are LBBB, more than half. And this LBBB results into electrical and mechanical dyssynchrony, and that dyssynchrony is associated with worsening of functional status of the heart failure patient. And these patients, they respond to cardiac resynchronization therapy very well. So that's why this makes a different population. Now, left bundle branch block with heart failure can be a mere association, because LBBB also suggests that there is a lot of fibrosis and apoptosis and myocardial damage in the left ventricle. But does it have a causal relationship also? Because in clinical practice, we see that patient first they present with LBBB, and then gradually over the years, there is cardiomyopathy and heart failure. So this may be one indication, maybe that this LBBB is early sign of cardiomyopathy and conduction system is involved before the muscles, or maybe the LBBB has some causal relationship with the heart failure, which is true, because LBBB, left bundle branch block, causes dyssynchrony, and that can contribute to origin of heart failure or worsening of heart failure, both. In this example, as you see, in normal cases, what you see is that the LV ejection and RV ejection, they continue for the same period, almost same period, or the LV, it precedes little bit the RV. But in case of left bundle branch block and wide QRS, what happens is LV ejection is prolonged. So aortic valve closes after the pulmonary valve, and LV filling time reduces. If filling time reduces, then the stroke volume will also reduce, because LV is not filled properly, so stroke volume and cardiac output will also reduce. So this is one mechanism where LVBB could be responsible for heart failure. This is from European Heart Journal, which shows that the mortality and the events in form of coronary artery disease, CHF, stroke, diabetes, everything is more in LBBB patients than control patients. LBBB with recurrent syncope is very common. Whenever we see a patient of LBBB coming with syncope, and if patient with bifascicular block coming with syncope, this LBBB patient alerts me more that he needs a pacemaker. In bifascicular block, I think twice, thrice and do all the tests. In fact, in LBBB patient also, you have to document that patient is having intermittent bradycardia, then you advise a pacemaker. But I have not seen any patient who has LBBB recurrent syncope not ending up with a pacemaker. So this is a very specific sign that patient is having intermittent complete heart block. Holter, nowadays this external loop recorder should be done for such patient to document bradycardia. Otherwise, this is one of the good indications for EP study where you can measure HV interval. If with LBBB HV interval is significantly prolonged, patient becomes that suggests a trifascicular disease and patient becomes a candidate for pacemaker. But if HV interval is normal, one can follow the patient clinically. But most of these patients would eventually end up needing a pacemaker. Problem comes when these patients suppose a patient of dilated cardiomyopathy with LBBB presents with recurrent syncope. This is a same ECG of a lady who came with the LBBB ejection fraction of 25% recurrent syncope. Now, if it is cardiomyopathy, you think of both bradyarrhythmia as well as tachyarrhythmia. So I admitted her and kept for EP study next day, but this patient developed complete heart block in the night, and we were certain that the cause of bradycardia, cause of syncope is bradycardia, complete heart block, but then question between CRTP and CRTD, those who are not the subject of this topic. Intermittent LBBB, most of the time we find it is also associated with higher chances of converting to complete heart block, and it is more commonly we see intermittent LBBB than intermittent RBBB, but in some cases it may be a functional rate related block which can be suggested on Holter if you see the development of left bundle branch block with heart rate changes. Exercise induced left bundle branch block is also a marker of underlying ischemia. The earlier few studies negated this fact, but this is true that patients who develop LBBB, they should be subjected to further testing for coronary artery disease. Approximately 70% of these patients who have LBBB on exercise test would have underlying CAD. Not only underlying CAD, but this is associated with more clinical events of cardiovascular origin, and it is a marker of severe coronary artery disease. I remind you that left bundle branch block has a dual supply from PDA as well as the LAD. So if LBBB is developing on exercise, that may suggest a triple vessel disease. So that way exercise induced LBBB is a specific finding and should be taken as marker of ischemia. So conclusion is that LBBB is not usually a benign condition and should be thoroughly investigated, may cause or worsen the heart failure. CRT is useful in presence of LBBB and heart failure. Acute onset LBBB with chest pain should be taken as MI, should be given benefit of doubt and should be thrombolized on time. Acute MI in presence of left bundle branch block which is pre-existing is difficult to diagnose, but is still possible and treated on time. Thanks a lot.
Thank you for Thanks for that excellent presentation. I have one question. As cardiac resynchronization therapy is becoming more and more popular and clearly beneficial, I wondered if you would comment on left bundle branch block versus non-specific interventricular conduction delay and how we differentiate them and whether or not we should be differentiating them in terms of response to cardiac resynchronization.
Yeah. See, as such, if we see the indication of CRT is just the wide QRS, it doesn't specify whether it should be LBBB or RBBB. But these studies suggest that RBBB these days is considered that they are the most of the non-responders are right bundle branch block. So in our practice, we recommend CRT to LBBB patients and non-specific conduction abnormalities if QRS is really wide, more than 140. And then mechanical dysynchrony in presence of these conduction disturbances revealed by 2D echocardiography or tissue Doppler imaging can further help us in selecting a good candidate for CRT.
Thank you very much. It was a wonderful session.
Thank you, sir. Thank you.
This is very important. This has been troubling me since a long time. Left bundle branch block can occur with normal axis. Left bundle branch block can occur with right axis. Left bundle branch block can also occur with right axis. The Marriott clearly tells if the left bundle branch block occurs with left axis deviation, then it is more sinister. And is it always necessary that LBBB has to have an LAD? And if the LAD is very high, say minus 60, because this is a very important thing. When you said LBBB is more sinister, yes, I agree, as you said, the Rosenbach series. But would you like to add axis? I would be very happy if you say yes. And many times I sit and think, this LBBB, this lady has got, but she has a normal axis.
Yeah.
And Marriott has clearly given in LBBB, sometimes they can have right axis also. So I would like to know from you, and I feel if LBBB associated with LAD, it's more sinister. If LBBB not associated with LAD, keep a good watch on that. Please comment.
Right. Your first submission that LBBB can have variable axis is true. That's true, because LBBB, just to say LBBB is not enough. It's a big structure. So level of block, and some studies like from Angelo Recchio has demonstrated that there is a specific pattern of left bundle branch block which helps in recognizing the beneficiaries for CRT. But this prognosis depending on the axis with LBBB, I am not aware if some expert can throw light on this. If there's some particular axis with LBBB is more dangerous than that I don't.
In general, I think that left bundle branch block associated with left axis deviation is generally associated with a markedly enlarged left ventricle and a worse prognosis.
Yeah.
Thank you, sir. I now request Dr. Martin Green to hand over a certificate to the speaker, Dr. Jitendra Singh. And I request Dr. Jitendra Singh to hand over the certificates to the chairpersons.